morning, everyone, and welcome to the 11th annual UNC Business of Healthcare Conference. We very much appreciate you joining today. My name is Jim Peterson, and I'm a second year MBA at UNC Kenan-Flagler Business School. And I have the pleasure of serving as the co-vice president of the Healthcare Conference. We've been working all year to design and implement a conference that brings healthcare thought leaders from around the country to discuss some of the most pressing topics in the industry. And we know that the day will be both insightful and thought-provoking for you. I'm joined here by my co-vice president, Carol Zhang, this morning, and she'll give you a brief overview of our theme and what to expect. Carol?
Thank you so much, Jim. Good morning, everyone. Welcome. I'm Carol Zhang, a second-year MBA student at UNC, concentrating in healthcare management and corporate finance. Thank you so much for participating in the conference. Our theme this year is about looking beyond the pandemic. It is very timely as we recover from the massive disruptions brought about by COVID-19. Now more than ever, leaders in the healthcare ecosystem are thinking about lessons learned from dealing with the pandemic and how to move forward and lead their organizations to the next generation of health. I hope you enjoy the conference. Without further ado, I will hand it over to Brett Stadt, our Faculty Director of the Center for the Business of Health and Associate Dean of MBA Programs.
Thanks, Carol, and thank you, Jim. Want to give kind of a great shout out to y'all, the entire healthcare club, for your work in getting us set up, as well as Aaron Leach in the background, who's made the magic happen here. But on behalf of the UNC Center for the Business of Health, incredibly excited to add my welcome for an amazing day. We've got a great lineup of sessions. I'll be back around lunchtime to join Gina Bartazzi, the founder and CEO of Kindbody, for our Dean Speaker lunchtime keynote. But for now, let's kick things off with our morning keynote panel, taking a look at the future of the patient experience, consumer expectations, and industry response. I'll hand it over to Sunny Goyal, our session moderator. Sunny's the Senior Vice President of the Diversified Business Group and Chief Strategy Officer at Blue Cross Blue Shield of North Carolina. Sunny?
Great, thank you so much. Really appreciate everybody being here, and thanks for the opportunity. Really appreciate it. As mentioned, Sunny Goyal, I'm the Chief Strategy Officer and Head of Diversified Business Group for Blue Cross Blue Shield North Carolina. And my job is to help develop and execute upon our enterprise strategy with the goal of achieving our purpose to improve the health and well-being of our customers and communities within the state of North Carolina. It's an honor to be here, and we'll turn it over to our esteemed speakers here as well to introduce themselves. Lauren, you mind starting us off?
I'll start us off. Thank you, Sunny. And thank you, Carol and Jim, for putting this together. We're really excited to be here. My name is Lauren Coyle, and I am the Division Vice President for DaVita Kidney Care in North Carolina. What that really comes down to and means is I help operate about 58 dialysis clinics for about 3,600 patients across the state of North Carolina. And it's a wonderful pleasure and just an honor to get to serve these patients and help take care of them. I am really excited to talk about the patient experience. Spending time with patients is one of the most fulfilling parts of my job, and excited to talk to you more about it today. I think we'll go to Nirav next.
Thanks, Lauren. Good morning, everyone. I'm Nirav Shah. I'm Senior Scholar at Stanford University, where I'm an internist, and I'm also the Chief Medical Officer of Sharecare in Atlanta. I'll turn it over to Rasu.
Well, thank you, Nirav. Hi, everyone. My name is Rasu Shrestha. I'm a radiologist by background. I'm the Chief Strategy and Transformation Officer and Executive Vice President here at Atrium Health. Atrium, as many of you know, is a large not-for-profit health system headquartered out of Charlotte, North Carolina, and we're really across the Southeast here in the United States, about 70,000 teammates. And we continue to grow. Really excited to be in my role here. I'm here now for almost 3 years in North Carolina. I can't believe that it's been that long, but moved in from Pittsburgh, Pennsylvania, which is where I was previously. The topic of experience and patient experience in particular is one that's near and dear to my heart. And it is because of the promise of excelling in patient experience that I got into medicine in the first place altogether. And in the role that I play, I have an opportunity to work with all of you and more to really take healthcare from sort of the transactional layers that it's been riddled in to the experiential layers that I know we'll talk more about today.
Lauren, Nirav, Rasu, thanks for joining us today. Before I get kicked off, just wanted to give a quick reminder to the audience. The chat is open, and our friends and colleagues at UNC will be collecting your questions throughout the session. I've got a couple of questions for our panelists here, but would certainly love to hear from each of you and share those questions. So let's get started here. So in summary, for this panel, we've described the new normal of healthcare ushered in by COVID-19 pandemic as patients are no longer passive participants in health, demanding transparency, convenience, access, as well as personalized products and services. In reflecting on the new normal of healthcare, I'm going to ask each of our panelists about normal from their professional lens. And Lauren, I'm going to kick it back to you. I promise not to harass you as the first question every time. But do you agree that there is, in fact, a new normal in healthcare? And if so, what would you cite as evidence of the resilience for the new normal?
Yeah, so I would say that I think there is a new normal coming in healthcare, but I would argue that in my experience, it's been less due to COVID and more due to the generational shift that we're seeing, consumer behaviors generally, and just what we're seeing with consumerism and healthcare and the expectations that our customers have. In my particular experience, my patient base tends to skew older and tends to skew a little lower on the socioeconomic band than what you see more broadly across healthcare. And so I think that we are seeing it in a more slowly moving way. But what I would also say, though, is that what we're finding is that technology and connecting with our patients and with all of our providers is providing an overall better patient experience. And so when we think about integrating with a wide swath of providers, our patients are incredibly sick. They, end-stage renal disease is the main thing they have, but they tend to have a lot of other comorbid conditions. And being able to connect with their other providers to provide them with a more holistic patient experience is really important. And our patients have come to appreciate that and like that so that they have fewer places moving throughout the healthcare system.
That's great. Thank you, Lauren. Nirav, same question to you.
Sunny, I'm an optimist generally, but I'm not 100% sure that we have a fully new normal as much as drastically as we'd like it to be. With COVID, they say that we got more in 1 month of COVID, more change than 10 years of healthcare reform. The reality on the ground is that in Stanford University, for example, we went from 0 video visits for primary care to 75% of our actual encounters done by video visits in just 3 weeks. Unfortunately, it didn't stay at 75%. It's back down to about 15%. So the pendulum swung. There were a lot of myths busted in terms of what doctors are capable of doing, what patients want. But the financial realities, the incentives underlying all of the payment of healthcare haven't changed. So despite I myself loving doing video visits and patients really appreciating it as well, Stanford has moved back to a lot of in-person care because you can order extra lab tests, you can do ultrasounds, you can do a lot of other things. And I'm being a little cynical here, that in a predominantly fee-for-service world make a big difference in terms of the margin and potentially in terms of quality and safety. But the new normal should probably be around 50% video visits. In practice, it's not even half that.
That's great. And Nirav, just for clarity, is that 15% greater than what it was pre-COVID?
Oh, it was a zero pre-COVID.
Right? Okay. Yeah. So we've certainly seen some improvements, but it has come back. That's good. That's super insightful. And Rasu, how about you?
Yeah, it's really interesting conversation here, and what's really interesting too is in the last 18 months, almost 2 years, there's no doubt that we rose to the challenge, right? We saw tons of heroics out there. The opportunity for us is how do we make this sticky? To Nirav's point, the pendulum swinging in the other direction. And, yes, there's this big talk about the new normal. And I agree. I think, we in healthcare, given how complex things are, like to go back to the things that we were used to doing in the past. So I don't like to call it the new normal. I like to call it the next normal. It's a little bit more intentional. It's not swaying in the winds of where healthcare is sort of wanting to go back to how things were in the status quo. So that intentionality, I think, is what we need more of. It's more of an in control approach, saying it's the next normal. We are defining what that next normal is amidst this VUCA environment, the volatility, the uncertainty, the complexity, the ambiguity that we're in the midst of. And to Lauren's point, I agree with what she was saying. I also see, however, that COVID has been an accelerant. It's in many ways shown a light in the cracks and fault lines that already existed in healthcare, right? So the opportunity here for us as we define this new normal, or the next normal, as I'm calling it, is, how do we intentionally move to that destination that we need to be at, right? How do we make sure that in that pendulum swing that Nirav is so right about, that we're not letting that genie back into that bottle, right? We're saying, hey, look, virtual care clearly has its place. Consumers are demanding this. They're more online, they're more engaged, they're more curious, and they're more concerned about their health and well-being than ever before. And we have all of these environments that we're in the midst of right now that, again, COVID was able to shine a light on. So how do we make sure that we're able to really make the heroics, the things that we rose to in the challenging year and a half, 2 years, and make it sticky, right? Make that essentially the blueprint of how we operate in healthcare.
That's wonderful. And let me ask a follow-up question, and I'll open it to all three of you here. As you kind of think about the new normal, the next normal, or even are we going back to the old normal? What are some of the big bets or investments that your organizations are making that are different than we would have in 2019? Is there anything that you feel like we have shifted into this world, even if we're going back to the old normal? An open question for any one of the three of you.
Sunny, I'll just jump in here. So, one of the things that we're definitely seeing out there is an inordinate need for us to really focus in on the ecosystem, right? So it's not just about any one of us. If there's one thing that COVID has shown us, it's the fact that we are part of this much broader ecosystem. And as much as we've been very internally focused, and I'm talking about, whether it's provider organizations, payers, companies, other entities in the public-private policy sectors, even, it is about the ecosystem. So that is a big element of what's then causing us to shift our mindset. And for us, the big bet that we're making, or maybe I'll talk about two things really quickly, is one is that it really is one of being a convener, right? So I think that's really important, and we're convening and facilitating the convening of a variety of different things across health, learning, and community. So very excited about, for example, here building Charlotte's first and perhaps most innovative medical school in the country, right here in Charlotte. This is the second campus of the Wake Forest School of Medicine. And this is an ecosystem play. It is us convening the learners, the researchers, the academicians, but also the clinicians and the entrepreneurs and the innovators in this ecosystem that we're building out. The second big bet is really around the consumer. And we're seeing a heightened acceleration in terms of how consumers are interacting with health systems and how they're engaging with their own health and well-being. And so what we're really doing is shifting much more dramatically to a consumer-first mentality. We saw it in the successes around our Atrium Health Hospital at Home program, our virtual care program, and other elements that Nirav and others were talking about here. But really that focus on desirability, accessibility, affordability, and scalability really are centered around the consumer. That's something that we know we'll have to really tackle with a vengeance in this next normal environment that we're in.
Love it. Lauren, Nirav, anything to add? Or?
Yeah, sure. I think Reza said it well, that we're moving finally away from physician convenient care to true patient-centered care, and the place-based provision of care to telehealth and other options and opportunities. Two other big shifts are thinking of care first in the home as opposed to in the clinic or hospital. So hospital at home programs and other opportunities to really shift the provision of care, including having direct care workers in the home, whether it's nurses or folks helping with the activities of daily living in the home, so you can get real world evidence around a patient and their experience more continuously, longitudinally, rather than episodically 2, 3, 4 times a year when they come to your clinic to visit. And finally, in terms of research too, where we once were really focused on academic medical centers being the place where research happens, now with decentralized clinical trials, with smartphones to be able to recruit people, we're now able to reach into rural America and other areas that traditionally were underserved for research, to find folks living it with their lived experience and recruiting them through their phones and understanding how we can help them along their journey in different ways, and understanding actually even different phenotypes of a given disease, because we're capturing people in their lived experience as opposed to artificially in a clinical setting.
Oh, that's great. That's great. And I'm gonna piggyback on this. Great. And I might turn this back to Rasu here, but building on what we're describing here, and as we kind of think about addressing patient experience, what do you think is our biggest opportunity in the current healthcare ecosystem to improve upon that experience? What do you think we're missing today? And are there any key blockers that you think are going to kind of hold us back from effectuating and making this ecosystem that you're talking about? Which I love that.
Yeah, so I'd quickly say that you said what's the biggest opportunity, and I'd say the biggest thing that we're all grappling with, whether it's in the metaverse or this universe that we're in the midst of right now, is trust, right? How do we really, in this environment that we functioned in, even in the last year and a half, 2 years, earn back the trust of our patients, our consumers, our communities? Because there's so much misinformation, I'd say even disinformation out there. How do we make sure that we're able to really earn that back? I think that's going to be really important. And I believe the way to get at that and also improve the patient experience that we're talking about here really is in co-creating and giving our patients and consumer control back into the data, the insights, and guiding them in the decisions that need to be made in the context of who they are, where they are, and what they're most concerned about, right? So this notion of co-creation that is contextualized, I think, is really important. And that's something that we're really adamantly focused in on, as we're not just embracing the core principles of design thinking, but really sitting down with our community, sitting down with the consumers and patients out there, listening, empathizing with them, but then alongside them, really co-creating the elements of what is most desirable for them. Because at the end of the day, that's how you get back trust. And I think, if there's one big opportunity for us, that's it.
Well, that's great. I'm going to go to an audience question here. Let me go, I think it's John Chapman here who's asked this question. What's the role of the health industry and patient expectations in improving the patient experience versus the role of government, if any? And how are you thinking about this in your roles? And maybe Lauren, I can turn this over to you to kick us off.
Yeah, I'd love to. So the government is the payer for over 90% of my patients, and well over 90% in North Carolina. And it's interesting because I think both the industry has a huge role in this, but the government can aid this enormously. And we saw that when the government moved to allowing payment for telehealth at the beginning of COVID, which they had never allowed before. And then you see that jump that Nirav spoke to 75% of visits by telehealth. We were able to have telehealth visits in the dialysis clinics from our providers in a way that we hadn't before, which was wonderful. But you also see the government playing in with the Center for Innovation at CMS with different payment models that really focus on patient experience and focus on a differential patient experience by moving the healthcare setting towards home. And in dialysis, that's been just an incredibly large influence for us. And it really helps to have the government shift some of the focus in that way, in a way that might accelerate where industry's going.
That's great. That's wonderful. Nirav, Rasu, anything to add to that?
I'll talk a little bit about where I'm excited to there with the payment systems that Lauren referenced.
Yeah.
We're used to incrementalism when it comes to change in healthcare. Oh, we got a little like 3% better this year. Yay, let's celebrate. Costs only went up 5% this year. Congratulations. And what we're seeing now with telehealth is incredible access. For example, with mental health, we never solved mental health. And I'm not saying we're even close to solving the challenge of access to good mental health services. But when you have 50, 100 options now that are digital, health systems paying for and understanding, even health plans directly paying for opportunities for folks to get self-diagnosed with depression and anxiety using online versions of GAD-7 and PHQ-9 scores, so that we can quickly get into cognitive-based therapy and other evidence-based treatments without waiting the average 3 to 5 weeks that in the real world is normal for getting access to mental health care. You can get it literally in minutes. That's the kind of transformative opportunities that we're seeing in areas which we thought weren't solvable. So with telehealth is a good example. I'd say broadly, it's digital diagnostics and digital therapeutics. Beyond, you just look at Livongo, look at almost any other unicorn, and a lot of them are in healthcare because people believe this is going to transform care and give the locus of control back to individuals. The barrier, though, is our traditional mentality. So, for example, during COVID, 2/3 of states allowed doctors to practice across state lines. I could see a patient in New York from California. Well, the pendulum has swung back, right? Interstate compacts for nursing have now achieved 38 states connected so that nurses don't have to get relicensed, which usually takes 8 months, 10 months, a year and a half sometimes to get a license in California. Now, 38 states do that, but not New York, not California, right? These are opportunities that are still blockers, barriers that we really have to address as a society and say the old guild mentality doesn't work for competition. It doesn't work for patients. If the rule didn't make sense some of the time during COVID, maybe it doesn't make sense all of the time with the state medical boards.
Oh, that's great. That's perfect. Thank you, Nirav. And actually, I'm going to piggyback on another audience question that's going to talk about some of the payment models here. So I'm going to steal from Lizzie Rekla, who is a second-year MBA student at NC State and also working at Blue Cross Blue Shield, North Carolina. So really excited about this question, being my fellow colleague here. She's curious to know how each of you feel about the current developments in value-based care payment models as changing the frontline patient experiences and our movement towards the new normal. And maybe Rasu, I can pick on you at Atrium. It's kind of how you're thinking about this.
Yeah, no, it's a fantastic question, and it really, I think, is the answer to how we need to be reframing the delivery of healthcare moving on forward. We've talked a long time about how we're already moving from volume-based to value-based healthcare, and clearly what we saw in the last year and a half, 2 years, whether it's in virtual care or mental health, as we've already talked about, or home-based care with our Atrium Hospital at Home program and such, is the fact that that transition from volume-based care to value-based care has to be accelerated, right? We saw in the pandemic that the fee-for-service model failed the test of time. I remember vividly in the first many months of the pandemic, we were bleeding financially, as were many other provider organizations. And so that is not a sustainable model, because we are here in service of our communities. And so the embrace of value-based care models and payment models is important, not just from the perspective of experience, and I'll speak to that in just a little bit, but also from the perspective of viability, this financial viability. I think that's really critical. From an experience perspective, having worked in a payvider organization for 12 years. This was at UPMC and Pitt before I came to Atrium Health. I know that when you're incentivizing value, you're also focusing in on not just widgets and the delivery of services and tests and such, but you're really focusing on the overall experience as well, right? So the care collaboration, the experience elements, the outcomes elements that, again, experience has a key role to play in, is what you're really incentivizing. And as we all know, you get what you incentivize, right? So the move again towards these value-based payment models is absolutely an imperative.
That's great. Thank you. Thank you, Lucy, for taking that one. And Laura, let me swing this back your way. Your company is also focused on patient experience and has been navigating a number of changes. But beyond even payment models, we need to think about safety protocols in the COVID-19 world and how that has impact. What are realistic expectations for patients to have about engaging with stakeholders in the healthcare system, and kind of what is the standard for a positive patient experience?
Thinking about this question is a really interesting one, Sunny, and it's one that we've spent a lot of time thinking about, because with the changes with COVID, and especially with the digital transformation, and even with value-based care models creating more holistic care, what it comes down to for each individual patient is that no fancy amount of that is going to replace the importance of a personal interaction with their caregivers, and feeling that trust with their caregivers and feeling like they are cared for. And no amount of digital, wonderful, things that we can put together are going to make up for a poor patient experience, right? With a caregiver. And so as I think about what our patients can experience, what the positive patient experience is going forward, I think one thing that fundamentally doesn't change is that human connection. And that's going to continue to be the base of a lot of our, of our healthcare interactions and of that positive patient experience. I think what we add on top of that really helps funnel into that is how can we use digital technology, and how can we use these value-based care models to make sure that we create more information coming to those caregivers so that they have the information they need to take the best care of the patient possible.
That's wonderful. Thank you very much. Perfect. Actually, I'm going to go back to the audience if my panelists wanted to open it to all of you. And I'm sorry if I'm driving you all a little crazy here, but I love all these questions coming in from the audience, and I hope they keep coming in. They're great ones. And I also love putting all of these panelists on the spot and making them sweat. So send them in and make them tough, please. That's great. So we have another question in here from Alitza, who's a dual MD MBA student at UNC, and in her brief clinical experience to date, seen the impact that immediate release of health information, chart notes, lab results, pathology reports, et cetera, has had on patients. And so kind of following on what you said, Lauren, here, around too much information, I think the question is, recognizing that an emphasis on transparency and a patient-centric system is critical, how do we balance this goal with the challenges of immediate release of results to patients versus kind of overwhelming them? So would love to, I can open this up to the panel and would love to see, but I think this is a really interesting question.
I'll jump in with a quick thought, which is just that I think it's wonderful for our patients to be able to get that information. And this is one of the places where digital is just huge for us, because you can have the push of the information to the patients, but also the patients are choosing to engage at that point. And so you see a subset of your patients who have downloaded the apps, DaVita, in our case, DaVita Connected Care, and another place, MyChart, and are going in and wanting to see that information. And I think it's just really empowering for our patients to be able to get that quick release and not have to have multiple layers to get there. And I've certainly enjoyed it from my own experience as a mother, wanting to be able to get my kids back into school and get my COVID, our COVID test back the moment we have a set of the sniffles.
So let me chime in here. As a radiologist, there's been a lot of debate for a long time now in terms of, when do we release the radiology reports, or for that matter, pathology reports or lab reports and such to our patients. And initially in the industry, there was a fair bit of pushback to say, hey, if there's a negative or a concerning test result, then it might behoove us to allow for the patient's doctor, the physician, to contact the patient on their own and explain the elements of, here's what the report actually means, or here's what the diagnostics of the labs really mean. So let's give it a couple of days. The push right now, and really it's a pull, it's the demand from our patients and from our consumers, is give it to me sooner, right? This notion of moving away from the information blocking, and that's a phrase that we're using quite commonly across the industry right now as something that we're moving away from, and releasing these reports and results sooner. I think it's a really positive wave. And what we've seen in the last several years, and at Atrium Health, we've been an early adopter of movements such as the open notes movement as well, is that when you're opening up the records, when you're creating that level of transparency and giving our patients and our consumers their information, their data in a much more timely manner, and then engaging them in the conversations that need to happen, right? Guiding them in the decisions that they want to make, then that level of trust that I talked about earlier actually goes up. The level of accuracy, the level of engagement actually goes up. So a big proponent of open records, a big proponent of opening up these reports and these results in a much sooner way, which is thankfully the trend that we're seeing in the industry right now.
Yeah, couldn't agree more. Couldn't agree more. And kind of curious at some point, we won't. This is not a question for the panels, but curious at some point to also kind of see how some of our big technology companies help enable some of that, and how they create even more of that ecosystem and connectivity and interoperability around these systems. So curious to see how this market evolves, but not a question for today. I'll keep moving along here. So listen, no matter where you sit in healthcare, the importance of both care personalization and care standardization actually applies. So the problem is that care personalization and care standardization actually seem to be somewhat at odds with one another. And our audience, I think, would love to hear from your professional perspectives how personalization and standardization can actually coexist. So Rasu, do you mind if I start with you? Do you see these paths as mutually exclusive, and maybe help the audience understand that?
Yeah, so it's chilly out here in North Carolina right now. I was taking Millie, my pandemic puppy, out for a walk this morning, and I was thinking, wow, if I was in Pittsburgh, I might start seeing snowflakes out there. And I say this because I was thinking, personalization and standardization, I think about snowflakes, because when we look at people all around us, we're like snowflakes. We're fragile, we're beautiful. You look at population health and you see analogies to snowflakes where, again, there's so much that is alike as you're looking at populations of congestive heart failure patients or chronic disease management in various ways. But precision medicine is looking at that snowflake under a microscope, right? So when you're looking at us under a microscope, we're pretty unique. And what works for one may not work for another. And precision medicine is really about that. So one is about decreasing variations in care, and that's population health. And then the other, precision medicine, is really about increasing variations in care and allowing for that level of personalization to that patient, to that consumer, to that circumstance. I think nirvana really is being able to do both and find that right balance, so you're able to risk stratify and adopt the best practices of what may work for large populations of patients and the best practices around them, but also then to cater to that N of 1, which is, I think, the imperative for all of us is to really find that balance between the personalization and the standardization and really cater to that N of 1. So that's the way that I view it. It goes back to that snowflake analogy.
And Lauren, maybe I can hand off to you next. And any thoughts to add to what Rasu said there?
I think he said it really well. I think the key is what he said really well that I liked, like thinking about that personalization and the snowflake versus standardization. And I see that within our populations where we've got enormous programs set to improve certain outcomes across the entirety of the 200,000 patients that we serve at DaVita, right? And then we also have programs where we are individually meeting on our risk stratified patients, on those highest risk patients every single week as a care team to figure out and really to answer the question. And the question we always ask ourselves is, what could we do this week to prevent a hospitalization for this patient? And those conversations are really particular to a given patient, and they're creative and they're fun. And it's really exciting to get to figure out what is the one thing we could do for this patient this week that hopefully prevents a hospitalization.
Well, thank you. Yeah, that's wonderful. I agree with you 100%. And Ralph, maybe I can turn to you for a moment too. What do you see as the impact of care personalization or novel products and services on population health and health equity?
Yeah, I see the mistake actually we make too often in healthcare is that we start with personalization. And I'm not saying it's not important, but as a doctor, I see the patient in front of me, I want to solve their problems right then and there. The reality is I should actually start with standardization. And it's not just me, it's my team, it's the systems we have in place, it's the approach so that we can rise to the top of the evidence-based hierarchy using standardization. Start with the 80% standardization of USPSTF preventative approaches, all the stuff we know that works. And then on top of the standardization, then build the personalization. And if we approach it that way, as opposed to let's start with what's unique, what we often do is unfortunately we forget or we don't get that mammogram and all the other things we know that can actually save lives. So I think there's been that tension of how do we do this? The more we offload doctors and let the standardization happen by systems and processes and teams, and let the doctor and clinical team each work at the top of their scope of practice, so I can spend time on the difficult conversations, on the diagnostic dilemmas, on the stuff I went to medical school for, rather than make sure I ordered that mammogram again, because I'm going to forget 1 out of 2 times probably. That's the approach I think we have to take. And we're starting to understand that as people have better and better systems in place, whether they're electronic or other approaches.
That's great. That's perfect. Thank you very much for adding that. I am actually going to go back to the audience here. I think a great question has come in from Ashutosh, one giving rave reviews of our 3 panels here, saying a very interesting discussion. But the question from Ashutosh is, what are the key current challenges during this next new normal for providers and payers? And I'm going to kind of add to that, bring it back to patient experience, and kind of how do you think that actually impacts patient experience and the quality of that experience and care that we're providing to them? And I'll open that to anyone.
I'll start with the provider challenges. If you asked a doctor 4 years ago, 3 years ago, 2 years ago, 1 year ago, even today, what are their biggest headaches? And they'll start by saying, Epic, Epic, Epic. Right? It took me 45 minutes to admit a patient in the old days. With Epic, it takes me an hour and a half to do that exact same amount of work. And I would argue that it's probably not higher quality because all the drop downs and other stuff. So we know what the challenges are. There's good uses of technology. There's barriers with technology. Those kinds of simple things that we still haven't fixed. I'm still waiting for the opportunity where I can just sit in a room with the patient, have a normal conversation, and the AI chatbot NLP processing engine writes 3 notes for me, one for the patient in patient language, one for me for my clinical notes so I can see the patient the next time I have the clinical stuff summarized, and one for billing purpose. And those are 3 different notes, not one note as it exists today. And the technology exists. It's about, is it favorable for some of these large EHR makers to make any changes because they're minting money right now. So I'm a little, upset with where the state of affairs is. It's very hard for most doctors today because we're just pounded with, oh, don't forget to do this. Did you forget to do the screening for substance abuse? What about domestic violence? So we're just getting added more and more to our plates without actually getting the support we need to spend quality time with the patient to understand the patient's goals of care and helping them along their journey.
Yeah, no, that's a great answer. And maybe Rasu, since we're talking about Epic, I'm pretty sure Atrium is also on Epic. So anything you'd add to that question?
Yeah, no, for sure. And that's a great point there. We were one of the largest and most complex Cerner sites in the country, and now a big Epic site as well. And when you think about the challenges in terms of experience, both from a provider as well as from a patient and a consumer perspective, I think one of the biggest challenges there is really one of silos, the data silos that exist out there. And traditionally, when we've been looking at interoperability, it's been about, hey, let's have meds and allergies and immunizations and problems and labs, typical domains within the electronic medical record system, the EPICs of the world. Let's have them interoperate with each other. And to Nirav's point, we were incentivizing our vendors, the industry, in the wrong way. We were saying, hey, it's okay to have proprietary standards out there, and hence interoperability was not a thing, right? And today, there's this mentality of a crawl, walk, run approach to interoperability, and the adoption of national standards is actually gaining momentum, which is just amazing. But I think the interoperability challenge is one that's broader now, because it's not just about clinical data, it's about claims data. It's about data around social determinants and patient preferences and eating habits and such as well. So for us, the opportunity from an experience perspective, because the patient, the consumer, doesn't really care about all these APIs, the challenges of interoperability, the technologies, even the AI solutions that we may have at the back end. What they really care about is, are we getting to them what they need, what they're desiring in an experience that actually matters to them, right? So for them, they need for technology to be invisible. And I think if we do innovation and interoperability right, technology then just becomes invisible. And that's what we need to get at, is how do we really have the data flow much more freely, adopting these national standards, adopting these APIs and the open solutions that are out there, make sure that we're then able to really cater to the specific experiences and the needs of our patients and consumers.
That's great. And let me double down, actually, got a great question from the audience here, from Austin Cornell, that actually hits exactly what both Nirav and Rasu you've been talking about here. How is the patient and members' experience simplified if a payer, provider, hospital, and digital health services all have their own apps, their own portals, their own engagement, navigation, coordination services, and on and on? Isn't this just more touch points and complexity? How do patients manage through all of this, and kind of what is your strategies around this?
So let me start. That's actually what Sharecare's promise is that all your health in one place, right? Where I work, it doesn't matter what flavor of a mental health app you want or a diabetes prevention program you want. All of it should be in one location, so that you know what you're going to pay for care, you know what your copay is, you know what your benefits allow, you know what and so you get digital diagnostics and therapeutics all through a smartphone. There's a big digital divide in America when it comes to broadband in rural areas. There's no digital divide, according to a 2019 Pew survey, when it comes to smartphones with a cellular plan. Almost every family has at least one of those. And so if you think of the smartphone as access, as the opportunity for telehealth, as the opportunity for interacting and engaging members and patients, that actually lowers the digital divide. It improves access. It allows folks to engage with their healthcare experience in one place. And I think that there is too much confusion, and that's why companies like Sharecare are trying to simplify it. If you build it, will they come? I don't know. When was the last time you logged into your insurance company's portal? Probably because you had a bill that you had to understand, and that was the only way they'd let you see it. The reality is, it's not a Netflix-like experience for folks. It's not Instagram. It's not. And if you build the right experience, then people will actually use it. And our goal in the attention economy is to steal attention away from the Facebooks of the world and get you engaged with Sharecare and platforms such as that move you along toward your health goals, as opposed to move you along toward the next hour of not sleeping because Netflix auto-advanced to the next show.
I agree with something Nirav said there, which is just that if you build the right experience, people will use it. And I think we saw that especially at the beginning of the pandemic, and we've seen it continue through the pandemic without a drop off on some of our education experiences and some of the key pieces of outreach, where we see that our patients and their families are getting a lot of value out of them, and they are continuing to demand them in a digital and telehealth platform, generally, as Nirav said, through their smartphone. through one smartphone in the family. And that has been really interesting. I would say though, for the provider, I still think the multiple platforms is something that is challenging and that I hear about from my nephrologist quite frequently, is that they're in Epic in their hospital, they're on a different platform in my dialysis unit, they're on a third platform in their own offices. And trying to keep all of that together is extraordinarily frustrating for them.
Yeah. I completely agree. And part of that question, and it was a really insightful question. It's going to, make me think more in terms of the opportunities here. Part of that question was also about, not just the various flavors of the apps and portals and engagement, but also about navigation. And it was really interesting. So yesterday we were in a half-a-day session here in our Enterprise Academic Forum, really across Atrium Health, our key researchers, academicians, and others, deans. And we're talking about some of the opportunities here. And Dr. Jeff Rose, who's the president of our Sanger Heart and Vascular here, he said, a system that needs a navigator is a system that needs to be redesigned. And I tweeted that out last night, and it's now, I think, on fire right now, that particular tweet. And it's true, right? And that's the challenge that we're in right now. The complexities of healthcare are just mire. And to Nirav's point, I think what's really important is that digital front door, right? Making sure that the experience in that digital front door is front and center to what that patient or that consumer really needs.
Yeah, that's a great answer, and I completely agree with it. And I'm appreciative of the fact that I'm a moderator, and as a payer, don't have to answer these questions. So keep them coming tough. I love them. So maybe I'll take another question here from Robert Nelson. It's a great question that kind of piggybacks a bit on what Nirav you were saying, but I might focus this throughout Sue. The pandemic has exposed many challenges and opportunities within our healthcare system. Robert would love to hear about how each of your organizations are working to address the disparities of care and access to care issues within your markets. Hey, Russ, if you wouldn't mind, I'll start with you. I know this is a big piece for you.
Sure, Sonny. Thank you so much. It's a great question, Robert. So thank you for asking that. I mentioned earlier that the pandemic's sort of shone a light on the cracks and fault lines that already exist, and the disparities in care is something that we're really, really concerned about. We created, even in the thick of the pandemic, it was more of a double downing on our For All mission, right? So the mission of health, hope, and healing for all is something that Atrium's really proud of. We created a social impact committee of the board, and we're really focusing in on the specifics of how do we even eliminate the disparities that exist out there across the communities that we serve in the Southeast. And so everything from really leveraging the power of data to better understand our communities, to heat mapping using GIS solutions, the disparities even amongst the zip codes, right? So everything from the earlier days of the pandemic when we were, really trying to test and understand how we might be able to help our communities, the pop-up clinics, you remember all of that, the triaging that needed to be done, to then the vaccinations and the treatment elements as well with our hospital at home program and our mobile clinics that were able to be deployed in the underserved populations, not in a manner of weeks or months or longer, but in a matter of minutes. Seconds, right? And we were able to see really remarkable sort of, flattening of the curve between the haves and the have-nots, where, the mass vaccination campaigns, the specifics of the solutions that we're pushing out there in the underserved populations were very targeted, right? And we're able to deploy these in a manner that we just hadn't been able to previously. And the key to all of this was data. The key to all of this was understanding the specifics of, the resources or the lack thereof in those underserved areas, and then making sure that we're able to maximize in on the relationships that we're able to build with community leaders, with faith-based leaders, with others out in the communities, so that we're able to really gain trust amongst the patients in the communities out there. So we're just getting started, but I think that really is such a big imperative for us across the industry.
Yeah, couldn't agree with you more. And it's an industry issue we're all going to have to tackle together. So couldn't agree more. Well, I'm looking at the clock here, and I'd love to wrap our panel time actually with getting each of your insights to just help healthcare leaders in today's world that are listening on this. And maybe Lauren, I can kick it over to you first. What are your what's your advice for students as they begin their professional careers?
I think I gave this advice in one of Brad's classes that I spoke in earlier this year. And it's to spend time thinking about what you want to do and the impact you want to have in this world. Chances are, if you're listening to this conference today and participating today, you are one of the 0.5% of people on this earth who get to choose what they do every day. And that is an awesome choice. And that is an amazing thing. So rather than spending time thinking about, what's the next thing I should do? What's the next box I should check? Think about where you want to have impact, what you want to do, and go out and do it. It is an incredible and awesome opportunity that you have. And it would just be a tragedy for you to not take advantage of that.
That's a great answer. Thank you, Lauren. You can see how smart she is by how many books she has, whereas I just have masks. So that's a great, appreciate that insight there. Russell, maybe I can turn to you again too. What do you think are the required skills and capabilities of the future healthcare course?
Yeah, I think about this in the context of what are some of the drivers, right? And we talked about some of these, and so just to highlight, information overload. We're data rich and information poor. Communication and trust. We talked about this today as well. This is the foundation of the patient relationship and the relationship with our communities and our consumers. And then maybe a third one that I'd throw out there as we talk about science and such as precision medicine, right? So the algorithmic approach to treating the average patient in a population are no longer relevant. And so precision medicine is really about having that precise treatment to that NF1. And when we think about all of the drivers there, I think from a skills perspective, the broader framing that I put out there for the students and others listening in is curiosity, problem-solving acumen, and really organization skills. I think that's really important. And then more of the specific high value skills that I'd put out there is data science. I think that's really, really critical from a skill set perspective. Project and program management. I need that in troves in my teams that I manage across Atrium Health. And then this notion of thinking outside the box in terms of experience from a consumer perspective, bringing in sort of the outside in thinking into the stoic complexities that healthcare is mired. And I think that's really critical too.
Oh, that's great. I love it. And Nirav, I will just say I'm trying to scan through the chat here as well. And you've certainly lit it up with a lot of epic comments. I'm
gonna get in trouble.
There's clearly a lot of, I hope there's no one from Epic on this call. You also have a couple of folks looking to get hired at Sharecare. So hopefully you're hiring it. I hope they'll reach out to UNC and a lot of the students on this conversation. Well, listen, thank you everyone for joining us for this morning keynote panel. And thank you to Rasu, Nirav, and Lauren for your participation and your wonderful conversation. And one more shout out to Nirav. He's on the West Coast, so this is very early for him. So thank you for getting up incredibly early for all of us here. Attendees, we will now move into the first round of breakout sessions. If you are interested in session 1A, digital innovation and advanced analytics in healthcare, you can stay in this webinar room. And if you are interested in session 1B, private equity in healthcare and the impacts on patients, please click on the link in the chat box. Again, thank you everyone for joining us today. Thank you again, Rasu, Nirav, and Lauren for being here today. And thank you for UNC for having us here today. We really appreciate it and appreciate all of your time.